So welcome to this afternoon session. I'm Paul Iaizzo, professor here in Department of Surgery. We're part of DMD, and I've had the privilege over the years to organize a cardiac keynote session. And we try to do it on timely topics and built on the legacy that I talked about before at lunch. You know, we're looking at engineers and clinicians that are driving, impactful areas in cardiac anatomy, physiology, surgery, or in this case, therapies. So we're really privileged to have two individuals here today that I was able to select. The first one is Henri Roukoz and Damijan Miklavcic. That's so hard for me to say. From here, he's a professor from electrical engineering from Slovenia, coming all the way just for this conference. And, invited these both, and they both said yes, which is awesome, because they're so busy individuals, and, they're going to give us insights. Now, normally I would sit, I've got their big bios here, and I would read through them and discuss that, but I think it's kind of fun for them to a little bit tell their own story of their own background and how they got here. So you've got a clinician that's using pulsed field ablation now almost routinely, and you have the pioneer in the whole development of pulsed field ablation and using electroporation for all kinds of different therapies. And now we have these two individuals in the room. So I think it's going to be a really exciting afternoon. So Henri's going to go first. We'll have him give his talk, maybe one or two questions. Then Damijan will come up. He will give his talk, and then we can answer questions. And then if there's time, we'll sit and have a panel. And then I'm sure afterwards, both of them are willing to stick around and answer a few questions. With that, Henri, who runs our EP lab here at the University of Minnesota, associate professor of cardiology, please.
Okay, hi everyone. My name is Henri Roukoz. I trained in cardiology and in medicine in Cleveland, and I did most of my cardiology and EP training here at the University of Minnesota. I stayed on for staff since then and became the section head in 2022 for electrophysiology at the university. I'm here to present to you clinical applications of pulsed field ablation. This new technology took the field by storm. When I sit with patients and I talk to them about doing an AFib ablation, I say, well, we used to do this the old style, which is radiofrequency ablation. And then I remind myself and the patient that the old style is just about a year and a half ago. So since then, a lot of tools have been FDA approved, and then some on the pipeline, which we're going to discuss some of them and how we use them. We'll get into it right away. I don't have anything related to this the content of this presentation. Most of my consulting is unpaid. So the traditional sources of ablation that we usually use is the two energies that most of you probably heard of is cryoablation and RF ablation, basically ice and fire. There are other sources that have been used through the years, ultrasound energy, but it just really interferes and causes a lot of side damage, and the energy you need to use to actually use it effectively is high. Infrared has been used, and laser has actually been gotten the closest assisting, and it did actually got approved, FDA approved, but the sheath was way too big, and the laser source is not perfect. So we stuck to basically RFA and cryoablation for a long time. And the way you do usually cryo is you extract heat basically from the tissue by injecting a refrigerant through the catheter that you're using. The most common catheter that we use at first was this single tip catheter, which injects the refrigerant or the nitrous refrigerant through this, and the nitrous refrigerant expands into the tip When it expands, it absorbs a lot of energy, making the tip extremely cold. And then you apply it obviously to the tissue, and then by applying it, you kill the cells that you're intending to target. The full cryoablation lesion is a freeze, thaw, freeze sequence. So if you freeze and you stop and you say we're done, we have an effect, there's a good chance that this damage that you did is reversible and the tissue is going to recover. So the full sequence is really freeze, thaw, freeze sequence. And then the biggest application in AFib, which is later came on, this was what we used for a long time, but this was really the single shot approach to pulmonary vein isolation, where you have the pulmonary vein that you want to isolate, and you have the cryoballoon from Medtronic that gets applied against the vein, and then the refrigerant gets injected in a circle about a third into the balloon, and that freezes the whole circumference of the balloon, hence freezing the tissue around it. And you would have to, again, do the freeze-thaw-freeze sequence to get the full lesion. That sped up the application of pulmonary vein isolation in AFib. The other source that was traditionally used for a very long time is RFA, radiofrequency ablation. And as you probably most of you know, the way it works, you put a patch on the thigh of the patient and you put the catheter inside. You apply a high radiofrequency current through the catheter. That current goes through the catheter tip into the body tissue, back to the patch, and then that patch goes to the ground, and that closes the circuit. What happens is heat gets generated at the point of maximum impedance in the circuit, which is the interface between the catheter and the tissue itself. So what you do is you generate heat at the surface, and then most of the damage done to the tissue is with convective heat. So that heat gets conducted into the tissue slowly. So you need time when you apply these lesions. But those lesions were mostly irreversible, but they are somewhat limited. They're limited by how much depth you can get. And when you put it into a tissue that doesn't conduct electricity very well, i.e. scar tissue of a heart attack in a VT patient, for example, it doesn't conduct very well, and those lesions don't drive depth into that scar as much. And this is the way we did AFib ablation before, which is, this is your left atrium, and your goal is to do pulmonic vein isolation, because the triggers for AFib happen to be in the vein most of the time, especially early on in its evolution. And this is your left atrium, the posterior wall with the left inferior and left superior veins, right superior and right inferior veins. And what we used to do is go dot by dot around these, in a circle around these veins. And once you close that loop, most of the time you would end up with an isolated vein. And what you're seeing here is a voltage map. So all your purple is healthy tissue, good voltage, and your red is basically no voltage, very low voltage. So the difference between here and here is you isolated the 4 sets of veins with 2 big circles. We call that wide area circumferential ablation. Now, there are problems with this approach. Obviously, first, if you have scar tissue, the RF doesn't get in. But also you have the opposite problem, which is your atrial tissue typically is very thin, much thinner than a ventricular tissue. So when you use heat or cold, whatever thermal energy you use, temperature does not discriminate. So if you're heating the atrium, and let's say the esophagus is right behind the atrium, you can drive that heat into the esophagus and hurt the adventitia of the esophagus, the cover cells of the esophagus. And sometimes the way it heals, they connect together. Once you damage the barrier between the 2 organs, they can connect together, causing a fistula. And this is an example of a fistula here. This is the esophagus with air leak going in and out of the bloodstream. The presentation of this would be endocarditis, emboli to the brain, waves of strokes, and it's a deadly condition if it happens. You have to recognize it fairly early and intervene early also surgically. You can't wait. It's difficult to diagnose too sometimes. It does happen very rarely in the situation, but it can happen, and I'm pretty sure it's underreported. Not everyone is going to be proud of reporting or having these complications and saying it out loud. But this can definitely happen as one of the complications of AFib ablation. As you can see, most of the outcome of this complication is death. That's why we take it very seriously. The other organ that could get affected is the phrenic nerve. The phrenic nerve goes right here in front of the right pulmonic veins. And as you do the ablation, again, temperature, or either you're using cold or freezing, it's going to go through the tissues into the phrenic nerve, and it's going to affect its function. You can cause phrenic nerve injury or even phrenic nerve palsy, and this is a condition, although not deadly, it can cause a significant morbidity for the patient, and it takes a long time to recover. This is a recent paper coming out that reported a significant amount of phrenic nerve injury, still below the 1% incidence. However, it all depends on how you look into it. So if you're relying on just the patient reporting to you that I have phrenic nerve injury, then that percentage is small, because most of them get the injury and then within a few weeks they recover on their own and it goes. But if you're measuring the phrenic nerve movement, or CMOS, that where you can measure the contraction of the phrenic muscle, the diaphragm, with the phrenic stimulation, that tells us a very different story. Actually, a lot of these patients get injury and they recover pretty fast afterwards. So thermal source of energy to cause ablation doesn't discriminate. It can go into phrenic nerve, it can go into surrounding organs. Hence the pulsed field ablation, the interest in pulsed field ablation. So pulsed field ablation is a non-thermal energy. Now, we don't want to be too confident when we say non-thermal injury. I'm pretty sure you're going to explain more about that. But it is theoretically a non-thermal energy that uses trains of high voltage impulses, very short duration impulses, and they cause a process called electroporation. As you can see, those impulses go and decrease the impermeability or increase the permeability of the cell. And as that damage to the cell membrane increases, it becomes at some point irreversible, and those cells die. The cardiac myocytes are among the cells that have one of the lowest thresholds to these fields. So it is very sensitive to pulse field electrophoresis. Hence, this technology has the potential of being very cardiac selective. So if you apply it to a cardiac tissue and there's esophageal tissue next to it, let's say behind it, or the phrenic nerve, the cardiac cells are way more sensitive to the train or energy that you're delivering. Hence, it can only ablate the tissue or kill the cells that are cardiac, but not the surrounding cells. So this is, in theory, where pulse field has a big advantage over thermal energies for ablation. And then, obviously, we all say it's non-thermal, but and this is a very simplistic way to present pulse field, is between the pulse duration and the electrical strength of the impulse, you have basically 3 zones as you go up this way or that way. And you have first the phase of where you have reversible electroporation, where you could cause some electroporation, the tissue is going to be stunned, and then at some point it can recover. It can take a few minutes, it can take 45 minutes, or it can take 2 days in our experience on the clinical side. What you want to be is in this zone, is the area of irreversible electrophoresis. So you want to deliver a duration long enough and a pulse strong enough to be in that zone of irreversible electrophoresis. And obviously, if you increase both the duration and the energy, you're going to slide into what we call the thermal injury. So now you're going to generate heat that causes the cells to die, which is very equivalent to RFA, which can cause the same limitations and same problems as we've seen with RFA before. And like I said, it's a very simplistic way of looking at this, but truly the pulse field that you're applying implies playing with the time to delivery, how many milliseconds, how much time you deliver over, the plateaus, the waveforms, in what range you're delivering the pulse field. And most of the pure electrophoresis happens in the nanosecond range. The millisecond range causes the most heat generation, but it also causes the most damage besides just the apoptosis. So pure apoptosis is when you're delivering very, very small trains. Every company pretty much at this stage have had their own recipes, and they studied this, and they're mostly landing in this zone, which is the microsecond range, kind of in between pure apoptosis and some injury to the tissue. But a lot of research goes into these waveforms, the pulse durations, and the exact recipe to cause the best electrophoresis. And most of this is actually catheter dependent, meaning that if you change the shape of the catheter, you're almost starting over, talking for most engineers that work on these things. So And clinically, this is the first experience that has happened clinically from an organized trial. It was for Farapulse, and there was an observational series first to make sure that they're safe, and they went through first applying monophasic pulse field, and they went through 3 recipes to finally achieve the highest level of acute, durable pulmonic vein isolation. And then with that, if you look at this, most of the studies, even with RFA, we went through a lot of phases of development to reach these higher levels of isolation acutely in the case. So this is what radiofrequency and cryo did, acute isolation. You can see from the get-go, PFA has had a high degree of acute efficacy during procedures, which was very promising. You rarely can see a technology that achieved that much, that fast, early on in its inception. And after that, so after the first observational trials, there were three main trials that really fixed the role of PFA in using an AFib ablation. The ADVENT trial with Farapulse from Boston Scientific, which compared Farapulse to both RFA or cryoablation, and it was at least non-inferior, with the numbers speaking for themselves. At least at 1 year, freedom of AFib was 73% versus 71%. And that was mostly for symptomatic paroxysmal AFib, so it comes and goes, and that's an early phase of AFib. The second trial, also with Farapulse, randomized symptomatic paroxysmal AFib, and they compared it just to cryoablation. They were not non-inferior, but also superior in their outcomes at 1 year. And then finally, the Sphere 9 from Medtronic that randomized patients with persistent AFib. And those patients typically are a little bit more advanced in the process of AFib, so they have more scar in the atrium. And they compared that to RFA, showing also non-inferior numbers, with the actual absolute numbers being actually higher as far as freedom from AFib at 1 year follow-up after the procedure. So again, not a lot of technologies came out like this as strong and stayed strong with subsequent trials. So the ones I've showed you are, and so one of the examples that I showed you here is Farapulse and Affera, which are the 2 main systems currently that we use. There are other systems too from Biosense Webster, but those are the 3 main contenders that we're currently using. There are other ones I'll show you later too, but those are the 3 main ones on the market. This is the Farapulse, Farapoint, and Faraflex catheters coming from Boston Scientific. We're using this already at a large scale in our paroxysmal AFib. I'll show you a case. There is the VeriPulse, OmniPulse, and Smart Touch Dual Energy from Biosense Webster. Those are the 3 main catheters that they currently have, and there's, again, other ones coming in the pipeline. And the main 3, those 2 are already widely used, and this one is in trial, which is the Pulse Select, first one to make it to market, Sphere 9, which is followed by, and this is a great catheter to use. We'll show an example of that too, along with the Sphere 360, which is a single shot. The 360, the goal is to put it in the vein and have it deliver all the PFA all around the vein and have a single shot approach to isolating those veins. It's mostly geared towards AFib. And this is what the ablation looks like now more these days for the last 1.5 years or so. And this is an atrium again with the left superior, left inferior, right superior and right inferior veins. And your goal is to go in and create a basket, engage the vein, deliver the packet, turn a little bit, deliver a packet, switch this basket to a flower mode. We call it basket to flower mode. You go in and have the flower, kind of the petals to the back to make sure you're pushed correctly inside. And you again deliver the first packet, second packet, you turn again about 36 degrees and deliver the second packet. And what you're going to end up with is basically a bunch of baskets and flowers all around the vein. And this is the end result, fairly similar to what we gear towards in RFA, regular WACA. You have the veins isolated on both sides. The procedure is much, much shorter compared to radiofrequency ablation. This is a much faster way to get isolation. You have to always keep in mind that these are acute, meaning that there is a little bit of retraction of these borders after you deliver energy. There is an air that's just stunned in that reversible electrophoresis zone. And this is another case with Affera from Medtronic, and this is they have their own proprietary 3D mapping system. This is a pretty advanced persistent to long-standing persistent AFib. So what we did, the patient also had flutter, right-sided flutter. So we wanted to do an ablation on the right upper chamber and the left upper chamber. In the right upper chamber, you can switch in this catheter with the Sphere 9, you can switch between radiofrequency ablation or PFA delivered by the same platform. So here on the right side, we did most of the line from the tricuspid valve down to the IVC with RFA, red dots. And when we get to the bottom here towards the IVC, we can switch to PFA because PFA is safer as far as generating heat in the IVC side. And when you're on the tricuspid side, you're closer to the arteries where you can cause vasospasm. So you avoid PFA in that situation. I will talk about that a little bit. But this is the left atrium with the 2 left veins and the 2 right veins. And we went around here and you apply dots all around similar to RFA, but those are much bigger applications, so you can go faster. This atrium is huge. This is an underrepresentation of what this atrium looks like compared to the other atria that I showed you because it's long-standing persistent. And we also managed to isolate the posterior wall also besides the veins, which is an application we do selectively for some long-standing persistent AFibs. So complications. So we said when we first came out with, when we first started using this is the preface was that pulsed field ablation is very safe to the esophagus. It doesn't hurt surrounding organs. But you also have to be aware of the applications, the catheter, the generator, fluctuations in delivery. Up to literally April 2026, I was screening for any reports that I've heard a report of esophageal fistula. And this was the very first, literally earlier this month in Heart Rhythm, came out the first report of an esophageal fistula with one of the systems with Farapulse. Now, mind you, during the case, they said they had a generator glitch where the two splines got too close together and the energy delivered was so high that usually there's a fail-safe in those generators that stops the delivery and tells you the splines are too close together. We need to separate them more to be able to deliver the field correctly. Otherwise, it's going to be high current levels. And they had 2 or 3 of such things reported in one area of the heart. And the esophageal fistula formed in that area where they had a high energy delivery that was stopped by the generator. Could it be the pulse field itself? Could it most likely thermal energy from that? So yeah, we have to be also take it with a grain of salt that not all energy delivered by pulse field is non-thermal. Some of it is clearly thermal. It can cause injuries if you're not careful. Phrenic nerve injury, again, depends how you look at it. If you look at it clinically, the reported percentage in the trials where you report the symptoms and it gets classified as 0.06%, which is very low and lower than RFA classically they reported in their trials. However, if you use CMOS, which is measurement of the diaphragmatic stimulation based on your diaphragmatic contraction based on the stimulation of the phrenic nerve, that number goes up to 40%. So 40% have some phrenic nerve injury during the case. Most of them recover by the time you discharge the patient the same day or the next day. And then only 1.6% can sustain at about 3 months, and that's in a mild form, mildly symptomatic. So you have to also take it with a grain of salt, like I said, with the premise of PFA not causing any peripheral tissue damage. Next is obviously there is a report of pericardial tamponade in about 1.14%, and those are PFA specific because, not PFA specific, system specific, because some of those catheters are really big compared to the RFA catheters. The RFA catheter classically is about 8.5 French sheaths that you use. These can about 17 French sheaths in some systems. And finally, there is the silent and symptomatic stroke. The stroke risk is on the lower side in these procedures, but the added mechanism of air emboli. So when you deliver these energies, you can create microbubbles that can also cause showering to the brain. and cause microinfarcts, even a lot of times obviously not floridly symptomatic, but they, if you do serial MRIs, you can see those microinfarcts. But we've seen that also with RFA in the area, in the era where we did not irrigate the catheter, and then we started irrigating the catheter, and we saw less of these down the road. And finally, and this is something very specific to PFA, is hemolysis. Hemolysis is basically you're destroying red blood cells and releasing hemoglobin in the blood. What's wrong with that is that hemoglobin, when it's free in the blood, it can go and cause all sorts of organ damage, especially the kidneys. And it can drop your hemoglobin because you're hemolyzing red blood cells. It decreases the ability to transport oxygen. It could cause, apparently there is newer papers that also says hemolysis is actually one of the risk factors for a vasospasm. Coronary arteries can go spastic, and hemolysis is one of the risk factors. There is less hemolysis, and the hemolysis happens especially with, mostly with bipolar PFA, because you're applying the current in between the poles, and those go into the bloodstream. So the field is built into the bloodstream, especially if you don't have contact. So if you're having contact with the tissue, the field can affect the tissue and does the ablation that you need. But if your contact is not perfect, almost the entire pulse field energy is delivered within the bloodstream. It can hydrolyze or hemolyze the red blood cells. And then a recent study came out comparing the different systems and the different modalities of PFA, and they showed that hemolysis is less frequent with unipolar PFA. Unipolar PFA is when you're delivering the energy between the tip and a patch on the thigh or on the back. Because you're driving most of the energy into the tissue, and there's less energy into the bloodstream, and there's more emphasis on contact, and because the form factor of the catheter lets you get better contact, unipolar systems have less hemolysis compared to bipolar systems. The other PFA-specific complication is coronary artery spasms. And this is a highly variable and thought to be related to intracellular calcium buildups. That's why we don't use PFA close to where the arteries are. For example, the mitral annulus, the mitral isthmus. This is where the left coronary, left circumflex lives, and you can cause spasms in those vessels up to 41%. As a matter of fact, if you, again, how you look at it makes those numbers change. If you're just looking at the clinical presentation of vasospasm, which looks like a heart attack when it shows up, it lasts about 2 to 5 minutes, those will be in the order of, anywhere between 2 and 14, 15%. If you're actually having an angiogram look at those vessels during the delivery, in some series up to 80% there's a change in the coronary artery, and then it decreases significantly and fast after that. So being close to arteries can cause vasospasms, and these events can be very dramatic because the patient will act like he's having a heart attack for about 2 to 5 minutes. We do pre-treat patients with nitroglycerin, high doses of it when we use it. I try not to use that unless I absolutely have to. But when we do, even with nitro, it doesn't prevent all the events. And there is some data coming out that the nitro might not play as big of a role. It might be playing a role as an aftermath where you're releasing the vasospasm rather than preventing it altogether. So currently, most systems that are on the market are approved for AFib ablation. And most form factors of catheters are also geared towards isolation of the pulmonic veins. So it's mostly for the treatment of AFib. But once we saw these results with the atrial tissue, we started thinking, can we use this in the lower chambers, in the ventricular tissue, so for VT ablations and for PVCs. So the efficacy still remains limited in the ventricle because, one, with RFA, what are we even contemplating using PFA in the ventricle? Like I said before, the RFA doesn't reach good depth, and the ventricle, you need depth because the muscle is about, on average, 1.2 centimeters thick. So, and your RFA lesion is about 3-4 millimeters on deep on Christmas. So, and then if you have a scar there, you're lucky if you get to 3 millimeters, depending on the heterogeneity of the muscle. The lesions are also heterogeneous, and there is long procedures. So when you apply RF in the ventricle, especially if you have a very thick scar, you're applying 60 seconds at a time, 2, 3, 4 times in a single spot, and then moving and applying. So it takes a long time to deliver, and that is if you don't get a reversible lesion at the end of the case. There is also risk of collateral thermal damage, the same thing as considered in the atrium, but this time mostly for the phrenic nerve. PFA offers a non-thermal and tissue-specific short delivery alternative, so we should contemplate using it. And there was multiple studies that came out first in the animal, on the porcine model, and then few in humans, and we'll go over some of the, I'm not going to go over study by study, I'm going to just put them all together here, but summarize them in this table for you. So what it told us, and these are the different systems pretty much that were on the market that were used in the animal, and some of them actually are still on the experimental phase. Most of them used bipolar PFA, but some unipolar PFA. But what they saw is, one, PFA can deliver deeper lesions and more transmurality than RFA. The depth can reach up to about 5 plus minus 2 millimeters. So you can hit 7 millimeters if you want, which is very tough to reach with RFA. You have in scar, and this is where the biggest advantage of PFA, in scar tissue, so in late chronic models, animal models, where you cause a heart attack and you come back and do an ablation later, about 2 to 3 months later, it showed that it can reach deeper into the tissue and take away the channels that you're looking to take away, for example, a VT ablation. Better so than RFA. And then it does enhance. So contact at first, when PFA came out, there was this phase of, I would say some of it is marketing more than anything else, where you don't need contact with PFA. You just get close to the tissue and you'll find. These studies showed that you do need contact. You don't need 70 grams of contact, but you do need contact in pulse field ablation delivery. But that contact becomes, as you have contact with tissue more than 5 to 10 grams, that curve starts breaking a little bit, so you don't need to push the catheter as much into the tissue. It is also repetition dependency. So most of one of the studies showed that if you deliver just once and move on, that depth is not as much as you'd like. Usually you need to deliver about 4 lesions, but if you look truly at the data, once you hit the second lesion, your gains becomes slowly decreasing as far as depth. And then finally, contact is important. So that was followed by 3 main studies that looked into VT ablation and PVC ablation using PFA. The first one was with a thermocool catheter from Biosense Webster. And that's catheter that's the same as the RF catheter that we used before. It was modified to be able to deliver both PFA and RF. Acute success was reasonable in the 80%. The problem with this is, especially for PVCs acute, the problem with this is the high recurrence rate, especially with VTs later on. So they achieved reversible electrophoresis and not irreversible, which is what you really want. And all of them have the same story except this last one, where they used the tacticath where it was higher, but they also had a little bit more complications. But overall, it's not too shabby for a technology like this being used in a very, very hostile environment like ventricular tachycardia, especially for structural VT. What to expect down the road and the trials currently ongoing. There is 4 main trials. There's more than just those 4, but those are the 4 main ones that are running. The first one is with the field force. So I'm going to show you the design of the catheter. With FARAPoint, with thermocool, and with Affera system, that are expected to be either later this year or later quarters in this year in 2026. So most of them are done recruiting in June of 2026. And this is an example of ablation that we just did yesterday. This is not necessarily FDA approved, but we did a successful VT ablation with the PFA. The mapping system here showed us where potentially the isthmus is, and we successfully ablated. So this is an activation map, and this is a voltage map. This is the base of the heart, the apex of the heart. What you see in red, this is a patient who is on ECMO, EF of 10%, VF storm, VT storm. So he had a VF VT ablation. So the heart is pretty much half dead, and we're trying to support him to get him to transplant. So what you see here, red is scar below 0.5, and the purple areas on the side, the lateral wall is still alive. This is activation map where we color code time. You take a reference and you color code the time. And you see late here an early breakthrough of the VT through the upper anterior, mid-anterior septum into the anterior wall, and applying the PFA right there in the area where the VT breaks made the VT non-inducible. Obviously, we haven't waited yet a few days or a few weeks to tell whether this is going to stay or not, but this was a fairly efficient approach to the VT ablation. It happened relatively fast compared to RFA. These are the catheter profiles that are coming. So this is the Smart Touch Dual Energy, which is the exact same catheter, just modified to be able to deliver both energies. Sphere 9 is already on the market. A lot of physicians have used it already. And this is a catheter that can deliver RFA and PFA. This is the FARAPoint catheter that is being currently also trialed in the VT arena. And this is an interesting design from Field Medical, where they get the electrode inside the catheter. The catheter has a lumen inside of it that pushes fluid around it. And the PFA energy gets applied between the inner electrode and this ring electrode, with the tip being completely insulated. They inject fluid, and what they're claiming is that they can do field bending by controlling the perfusion through this. They can do field bending by making the energy higher and higher. You can pick how much depth you want with it and how much, what directionality and how big your lesion wants to be. The same thing with the Centauri system that's also CE marked now in Europe. It's not in the US, it's not FDA approved in the US. And this system also has multiple levels of energy where you can dose your depth in the ventricle. So those are the promising technologies already tried in Europe, and some of them are being tried currently in the US coming up. Future directions, obviously, we're looking into, all companies are looking into new catheter designs, new catheter electrodes and form factors, and new waveforms and energy levels for both AFib and VT. The treatment of non-pulmonic vein triggers in AFib, so everyone is focused on the pulmonic vein isolation because most of the previous trials showed that anything additional to that adds very little in the terms of outcomes. But now that you have an energy that actually effectively can, let's say, isolate the posterior wall more efficiently than RFA and less dangerous than RFA when it comes to surrounding organ damage, there is a new look into non-PV triggers like posterior wall isolation, SVC isolation, and so forth. And then finally, there's evaluation of the lesion durability and make sure that what we're applying and seeing acutely during the case is actually lasting 2 to 3 months. With that, I end my presentation. Thank you very much.
Well, that was fantastic, Andre. While Damijan's going and set up, we can maybe ask a couple questions from the audience. Yep.
Yeah, with regards to, two-part question, with regards to pericardial tamponade.
Sorry, I was just looking at it.
Is there any consistency in the location of that?
The tamponade was mostly from a microperf, mechanical microperf, when it comes to the bigger sheaths. Currently, the FARAPulse, for example, sheath uses a 17 French sheath. It's big size compared to
Right.
8.5. So usually in the back of the atrium is where the potential injury happens.
And what is any idea of the mortality for?
Usually from the reported, there's non-reported cases we've heard from has had a mortality before, but from reported cases, most of these cases end up being saved. Usually they're very mild, and they're not. They don't cause necessarily a massive bleed. So.
Another question for Henri. All right. I'm coming.
You mentioned about vasospasm and like the risk of coronary artery spasms. Do you think bipolar versus unipolar makes a difference in the effect of it? Because like bipolar is more localized with the field.
Yeah. So on average, clinically, we're seeing a little bit more vasospasm with bipolar, especially when you apply it, concentrate the field all into that same area, versus unipolar that dissipates as soon as you catch the tissue, you dissipate pretty fast after that. So we see that more with bipolar in general. There is also another thing that I didn't mention, just to add to the question, is it's not just the vasospasm that we worry about sometimes, it's the hyperplasia. So there is a study that showed that if you look at these arteries about 3 months after, there is a build-up of hypertrophied tissue. The adventitia of the artery thickens up. Not to levels where you have to worry about a heart attack or an MI in that area. But it makes you wonder, because this happened only at 3 months, no one has done studies at 5 years yet. So yeah, it's mostly driven with the bipolar, but it was described with unipolar too.
All right, Henri, thank you very much, and we'll move on. Stick around, maybe get some more questions later.
So thank you, Paul, and these are my disclosures. Well, first of all, thank you, Paul, for the invitation, and congratulations for the 25 years of the design of medical devices. It's incredible, it's awesome. Now, let me move to 2 years ago, we published a paper which was the state of the art, and and so on. And the numbers of patients at that time were about 50,000. Now, last year, at the end of the year, in the fall, we were worldwide 1 million patients being treated already by PFA. So that's how fast it goes. And let me show you this, is the landscape, the competitive landscape of the approved devices last year. Yeah? And we had a presentation of a document, a scientific statement by European Heart Rhythm Association and other associations around the world, around the globe, and we have another one at the HRS later this week in Chicago. And this is what we have right now. And by the end of the time that you're going to actually read, for example, this paper, which is very helpful, I would say. It's lengthy, but it's helpful if you want to be updated. I had the privilege to contribute to this one as well as to this one. Both of these papers are lengthy, but they give you, I would say, a consolidated understanding and current clinical practice and the adverse events and how to deal with that. But let's look a little bit how this came around. Yeah? If you look at the graph, there was, nothing, no papers, no whatever. There was no PFA, no pulsed field ablation until 2020, basically. Then the term was coined. Yeah? Before that, it was electroporation. And after that, it's all about PFA. So people, they don't even understand what PFA is because it's so strong in I would say, marketing. Now, there are a couple of papers which are really, I would say, setting the tone from the beginning, 2007, 2 papers, one on each side of the Atlantic. And then there was a Dutch group which was the only one who was pursuing that for a period of time. But under the water, things were going on in companies mainly, until it came out. From Iowa approach, it became Farapulse, and then the Medtronic internal program came out, and since 2020 on, you see how the numbers go up. After FDA approval, this is actually a slide shown last year in San Diego at HRS. In half a year, a complete abolishment of RF, what my colleague speaker before said, to PFA. So a complete conversion. A little bit, let me say, more traditional movement of the field in Europe, but still, from 2020 to 2025, you see initial procedures, which were done traditionally by cryo and RF, are now 50%, and this is 2025, are going to be mostly done by PFA. So I like this one because it really it's like a magic. And you know, my boss, Loise Wodonik, who was actually spending quite a lot of time in Cleveland back in those days, he said, "Oh, this is too good to be true, Damijan." Yeah. So this is actually, if you see something like this, something's wrong. Okay. You have to start to doubt about that. So, but why did people think about it as you know, it's almost a magic wand? These are the images that you can see, and they are telling, and they will convince you. No pulmonary vein stenosis, no damage to phrenic nerve, no, you know, damage to lung. And this is, you know, it's really amazing. So no wonder people said it's non-thermal and selective, and they keep telling that. Yeah. And you've seen this slide. No matter what you say, in 1 million patients, 170 patients, and that's very conservative estimation, has been saved. These patients are alive that would not be alive, okay? Because of this change, because of this, you know, being taken by the storm of PFA. Now, PFA is really based on something which we know, and I work on this for more than 30 years. It's electroporation. So electroporation is best seen as a damage to the cell by damaging the cell membrane. So it starts with inducing the transmembrane voltage, which, if sufficiently high, will create small pores, will allow the reactive oxygen species to get into the hydrophobic domain of the lipids, will attack the non-saturated acids of the lipids, and therefore it's going to make the lipid bilayer leaky. That is damage. Plus, it can affect the proteins as well, partially unfold. Yeah? And that all is perceived by the cell as a damage. And now there's a recover that kicks in, and the cell tries to recover. Sometimes it survives, sometimes it doesn't. And we call this irreversible or reversible. The problem is that we do not know what is the point of no return. How much do we need to damage the cell to actually get, you know, to the point of no return, to irreversible damage? That's for me, it's great, because I have another 10, 20 years to work, yeah? And PhD students as well. But it's a little bit more than that. It's not only on the cell membrane, it affects also the physiology of the tissue. Because when the cell membrane is permeable, you will have the molecules leaking out as well as getting in. You will also see a response of the microvasculature. I'm going to try to show you some of the, you know, why and how of the clinical manifestations that we've seen in previous talk. Now, obviously, PFA is different from thermal in many aspects. And you see here in a table roughly how it shows. And one of the main reasons why PFA is so, let us say, different from radiofrequency ablation and cryoablation is because it's causing damage to the cells in a non-thermal way. That also means that it allows the matrix, the collagen, it's intact, and the healing is faster. So That is the important difference. If we would be able to choose the parameters specifically to, to tune them by the pulse duration or the waveform or whatever, magic, and the electric field strength, to get into this, golden area. Let's call it golden because it looks like good. In reality, that's not possible. Every time that we deliver the pulses, we will have non-linear, non-homogeneous electric field. The highest close to the electrode, close to the catheter, and then it falls off fairly rapidly. So we will have, perhaps if we want to drive the lesion deeper, like in ventricles, we're going to have a thermal damage around the catheter. We're going to have the irreversible damage, the golden area, and we will, beyond that, have reversible. And we all remember, the induced transmembrane voltage and then the action potential, propagation, nerve stimulation, muscle stimulation, and so on. Don't forget about that. So what we really are looking at on one side is thermal damage, then irreversible, reversible, then damage to the, or transient damage to the vessels, to the microvasculature, but then just the plain neural stimulation. So we're going to have all of that every time we deliver. So there's no magic about it. Yeah? If we just focus on the thermal, we're going to see thermal. If we forget about that and we focus on the gold part, we're going to have the gold. So this is what really happens. Most of the time, we focus on what we want to see, and we dismiss all the rest. But it's there all the time. Okay, so there's an interesting look into the history. Back in 1982, both electroporation, the term appeared the first time, coined by Eberhard Neumann, when delivering genes into the cells. But also, there was this electrical DC ablation, which we know as the fulguration. It was successful, but uncontrolled in a way. What it turned out is that, you had so much damage. But to be honest, the technology, first of all, they didn't know that at least part of that was electroporation. Well, of course, because electroporation was just named in the neighboring or, a distant area of science. But electroporation actually, I'm going to get back to this. So it was abandoned. The DC ablation as a fulguration was abandoned, and the RF kicked in. And there was a golden area of RF ablation until 2 years ago. Okay. Electroporation is used in medicine and has been used in medicine for drug delivery, for cancer treatment, and for gene delivery. And it's still used. But of course, it didn't make the impact the way how it's making impact now in cardiac ablation, in electrophysiology. So compared to we've seen the clinical results display and so on, just to give you, this is the fair comparison, I would say. Cryoballoon versus, let me say, a Farapulse, a single-shot device. And it's not like superior, but come on, we're close to it. And this is, this is 2 years, 5 years max old technology. A recent comparison from Europe, just presented maybe a year ago, 1-on-1. It's exactly the same. This is what we are talking about. The first report from the registry on 17,000 patients, mainly from Europe, entirely based on Farapulse. No esophageal events, no fistula, but no damage to esophagus. No PV stenosis, no phrenic nerve paralysis. There are some which were kind of not expected. So, you know, the coronary spasm, the hemolysis. And this is, you know, special. And this makes it very safe. With the new ones, we're going to go through them. This is a later cohort of patients from US, 40,000 patients, still the same technology, exactly the same. 0 atrioesophageal fistula, 0 PV stenosis, and of course now the terminology has changed a little bit. So we are now talking about persistent phrenic nerve injury, and we are talking about esophageal dysmotility. Okay, so there are fine tones that are coming out slowly. Now, let me remind you, electroporation as a sequence of events. I think this is really important. This is the only thing what I want you to remember when you go out of this room. Induced transmembrane voltage, if sufficiently high, will cause damage to the membrane of the cell. And if that damage is sufficiently high, the homeostasis will be disrupted to the level that the cell will not be able to recover. And that will drive and kill the cell. So that's the mechanism. And as I said, unfortunately, we don't know how this will be. Now, people say, so there are 3 mechanisms involved: lipid pores, lipid oxidation, and protein denaturation. All 3 are there at different time points. It's not just pores. It's we have a sequence of events that drives and causes the damage to the cell. What people will say is we have a special waveform. We can't disclose. Well, I can tell you, working for 30 years plus, you can cause electroporation with any kind of pulses. Single pulse, multiple pulses, bipolar pulses, monopolar pulses, or if you want biphasic and monophasic, you know, any kind of nanosecond pulses, millisecond pulses. So what's so secret about your waveform? I'm going to tell you later on. But let's first look at what happens really when we deliver the pulses, and if these pulses, you know, are normal, nice, we can pace the cardiomyocyte. The moment we go too high, we create a mess because of this additional leak current. And what actually happens is that the cell is now hyperpolarized. It can be hyperpolarized for, you know, 10 seconds, for a minute, or longer, or forever. But this was really the incredible thing for electrophysiologists, because the signals disappeared almost immediately. And because they were always in RF and cryoablation, they were also considering this disappearance of the signals as the final proof of ablation. They were overwhelmed by seeing this being achieved in a second. Of course, and you know, people said, this is done. No, you're not done. You need to deliver more pulses. No, but there's no signals. So it took a while. And the reason how I know that and why we know that is because we've done experiments. And simply what you do, you add a leaky current to the model and you achieve exactly the same behavior of the calcium transmembrane voltage. It can be explained simply by this. Now, of course, the time frame of pore closure, of lipid bilayer replacement, and the protein replacement in the membrane, it takes longer. Sometimes it takes hours. Yeah? Because there's no repair mechanism on the membrane level. You have to take it in and bring new ones out or fold them again. And that is also why the pulmonary vein isolation, acutely, they were all reporting 100% of isolation. But then, in redo experiments, in redo treatments, what they saw is that sometimes you had a patient with all four veins being reconnected. So what on earth was the operator, the EP, really doing if he got 4 pulmonary veins reconnected? And this was all because of, what we said. You don't need to be even in contact because you can stunt. Now, blood is a conductor. It's electrolyte. It's actually more conductive than the tissue. So even if you're not entirely close to the tissue, you still get the electric field there. The current flows. It's not like with the RF where you get all the heat away with the blood. But this really, it was done very elegantly, and it shows that if you are not in contact with the tissue, the lesion depth will be diminished. Yeah? But it takes time to learn collectively. This is, again, it's the same. This was done in the Paul's lab, in the Visible Heart lab. And controlling the contact force is not really what drives the lesion depth. It's the contact gives you the optimum, and all the rest depends a lot on what is the shape of the catheter, because some catheters, you just need to press them because they, the electrodes are somewhere on the spine, so you need to push to get them in contact. But in reality, you don't need more than just contact. Not everybody agrees with this view, but I think we are closing the gaps in between. So, but one of the reasons, one of the consequences of this, what I showed you, is that all the companies are now implementing some sort of contact, indicators. So that is checkpoint. We now know we need to be in contact. Is there a good way? Well, there's no best way, but everybody's trying. So I'm not going to really dwell on the efficiency and durable lesions because it's not my thing, but non-thermal and selective. So electroporation in vitro, what we do is we test, we put cells in the cuvette, we deliver pulses, we increase the voltage, and we get this kind of a curve. The permeability, the blue one, and the cells die, and this is the red one, the dashed. In between these two is where we want to be when we want to deliver genes, for example, and drug. This is where we want to be when we want to kill. So you see there's a little bit of a trick here. The problem is that if you look, the blue and the red, the dashed, they are not parallel. Yeah? You can see that even if you have 100% permeable cells, they will not all die. Yeah? And these two curves are taken at different times. One at 24 or 48 hours, that's the red one, and one at 5 minutes, so the blue one. So they are not there, they are not parallel, and they are in time separated. So that makes it complex. A little bit more complex is because electric field, that's the voltage on the right-hand scale, no, it's electric field, is really inhomogeneous. And this is what I showed you before. So we have the reversible and irreversible, and we have the thermal. And as we want to drive deeper lesions, we're going to get more and more thermal. And as we are going to drive more and more, being more and more thermal, we're going to be losing the selectivity, which I will dwell on later on. We've done, for example, because people were saying it's non-thermal, then all of a sudden people were saying, no, it's thermal. So what is it? And so we said, okay, we're going to do the experiment, and this is what we did. This was, so in vivo, in ventricles, MRI, cardiac MRI, T1, I'm going to show you modeling and all the stuff. And of course, we estimated what is the, what are the temperatures and what is the estimated lesion size because of the thermal damage. And it's really less than 2% in what we used. This is the worst case scenario, where we delivered 16 trains of pulses. Yeah? And you see the difference between the PFA lesion and you see the difference between the thermal. Now, the native T1 in the far right, you see the signal pointed with the red arrow. That's the thermal damage that you see on native T1 with RF. It's always there. You don't see it in any of the escalating doses, the blue arrows. When you look at the 3D late gadolinium enhanced cardiac MRI, you sometimes see something which resembles a little bit of microvascular obstruction, and this is because we also affect the microvasculature. But it's not because of the thermal damage. This is one of the first cases which was done by Atul Verma. He was then at Newmarket, and I was there. This was February 2020. Remember that was COVID. So after that, I went home, went to Zurich for another PhD. Then it was March, and everything was grounded. So, and then we had no flight. This is going to happen in Europe pretty much in 3 weeks. Again, not because of COVID. So what you see there, and it's a loop, you see bubbles. Okay, so where do the bubbles, so for me it was the first question, what are these bubbles? Where do these bubbles come from? So people now call me behind my back, he's a bubble boy. Yeah. And when somebody asks me, what do you want to drink? Champagne, I'm a bubble boy. Yeah. So where do you get the bubbles from? You see, these are three different catheters, the Varipulse, the Pulse Select, and the Far Away. And with each, you see a little bit of bubbles. Now the question is, where are these bubbles coming from? So in principle, you have three possibilities. That's the chemistry. It's very simple. It's either electrolysis, gasification of dissolved gases, so when you increase the temperature and it comes out, or the pressure, or the boiling. And all of you who cook pasta, you see the middle and the right one. Yeah, so the first one is just without boiling the water, you already see the bubbles coming out. So that's degassing. Or with the Coke as well, or with the champagne. Yeah. So now all of the companies have landed more or less in biphasic microsecond pulses range, correct? Okay. So you see, this is the monophasic. You see huge amount of bubbles. You see 100 microsecond pulses, again, huge amount of bubbles. But then on the far, this one, you see, it's running, but there's no bubbles. That's the biphasic microsecond pulses. So there's no electrochemistry. So the first two are electrochemistry. The last one is not electrochemistry. So where the hell are now the bubbles coming from if there's no electrolysis? When you measure the temperature at the same time, you see at this biphasic pulses, you see a temperature increase. So we've designed an experiment, I'm going to go very fast, where we were able to control, and we used the fast camera, and then we also did all the, the calculations, so the equations. So this is the engineering stuff, yeah. And then so now we can one-on-one compare the field distribution, current density. We can calculate the temperature. We couple that and blah, blah, and so on. And we can now, actually, we measured the current and the voltage, and we can now see exactly when the bubbles occur and what's the temperature at that time. And then we can play with different pulse parameters. And we see different things. You see, this is the monophasic 100 microsecond pulses. Then you see this one, which is a 2 microsecond. It just comes out and goes back. But then there's the last one. There's nothing. Yeah? Okay, so the big difference is high duty factor, low duty factor. Plus on the left-hand side, it's also a little bit of electrolysis. Okay, so that's, that's the wonder of having or not having bubbles. But that's in water. Water is nice, you can see, but it's not blood. Blood is a tissue. But coming back to the original, yeah, we still get the same. So physics has not changed in this, several decades. It's still the same. But we control now better. So now we're getting back to PFA is non-thermal ablative modality. Myocardial sensitivity could potentially limit collateral damage. So now we understand, and companies understand, that it is temperature that is present. They do measure the temperature, and they report the temperature, and they control the temperature, which is good. But then, again, we still have problems with, strokes. And one of the companies had severe problems, so they went there, they fixed the problem first time, and now the second time. And now the second time, they report how they changed. They increase the irrigation, and they will change the waveform. And it's now the new waveform, the new commercial. At the surface, the irrigation really helps. But when you go 3 millimeters deep, it doesn't really help a lot. It doesn't make a big change. Now, but the temperatures are different. You see the temperatures as you see them on the right-hand side. You also see that the waveform and the whole process of delivering is much shorter than it was before, which is good for you. Yeah? You like it because it's shorter. But my question was immediately, yeah? So this is the 3 millimeters. So this was the surface, and this was the 3 millimeters. So you see virtually no difference in temperature, whether you look at the irrigation or you don't have high rate or not. The main problem is that once you change something in the, reducing the heating, because those bubbles are from heating, yes? That was my point. Now, whatever you change in the pulse parameters in the waveform will also affect other things. So it can also affect the lesion depth. So when you do that, you have on the input, you have all these kind of things, and you try to kind of optimize it for the heating. What is now with the cell death? So that was my first question. And they showed me the data. I said, can I have it? And here it is. Yeah? So they did that, which I must say I like the transparency, at least to me. They should, of course, tell it to everybody, but they are planning to publish it. So we have lots of, parameters that we can play with. So this is 9, plus the shape of the catheter. That's for everybody to play with that. It's quite a challenge. Not only that, it has effect on different things, and these are the relevant, let me say, topics: the stunning, the irreversible, the reversible, the electrochemistry, the pain, the neuromuscular capture, and so on. Even small little things that you change, that you think they cannot matter. This is from the literature. You change the the interface delay, so the delay between the positive and negative phase of the pulse, from 5 micro to 1 microsecond, and your lesion depth falls down. If you do that at a different pulse duration as well. So it's not like a glitch, yeah? It's consistent. Now, you make a small change, like I showed you before, it can make huge difference. But how it affects the lesion, it's difficult to say. So you need to, as you said, you change something, basically you need to go to the beginning. So what I'm saying is we need to keep PFA non-thermal if we want to benefit from all what it has. But we also have to understand that there are other things that are going on. Plus, what I showed you was boiling in water, but in the blood, you have proteins. And proteins denaturate at 40 to 60 degrees. So you don't need to go to 100 degrees to misfold them, to affect their, capacity to hold something. Yeah. So I think this is important. Now, if I have a little bit of time, I do have a little bit of time. The selectivity, it's been said it's selective. Well, yeah. For me, that was a huge one, to swallow. Because, working for 30 years plus, we could electroporate everything, And that was really something that I couldn't just, I don't buy it. So, and where does this come from? You look at chronic time, like 4, 6, 8 weeks, the lesion, or you look at acute time, 2 hours, and you see no difference. And I mean, here on the acute, it's very difficult to tell whether the nerves are damaged because no stain will tell you. Because for the nerve staining, it takes usually a couple of, let me say, days to show up on histology. But when you look at the chronic time, the nerves are there, the vessels are there, so they must have been preserved. That was the original thought. So you need to come up with some sort of explanation for that. The experiments, and this is where you see, this was the internal program of Medtronic. The esophagus clamped and delivered pulses, but also RF. And you compare this, you see a clear difference. But when you go back at 8 weeks, you don't see any damage. If they wouldn't put the surgical clips in, they wouldn't even know where the ablation was done because it regenerates. And this is now, for example, more recent. They see, and it was reported, let me say, last year, they see damage to esophagus by pulsed field ablation, but of course, it heals within 2 weeks. So in 2 weeks, there's no more. So when you say, it must be that they were not damaged, the vessels and the nerves. No, they were damaged, but they recovered. And that goes well with what we know from other areas. So the message is that really the selectivity comes from the capacity of most of the tissues in the body to regenerate, to heal by regeneration. And this is not true for the cardiac tissue. Once you have the myocardial infarction, it heals in a different way by fibrotic scar. So it will never grow cardiomyocytes back. That's the selectivity, okay? So that's the lesson number 2 that I want you to take with. Now, the complication rates are small and low, and mainly we are talking about phrenic paresthesia, coronary spasm, and hemolysis nowadays. And of course, the phrenic nerve, if you measure the phrenic, you will see, of course, the compound action potential being affected and not coming to the 100% of what was there before. And that has been seen in animals, but it recovers. It recovers very fast. In fact, doing experiments, again in Paul's lab, we saw that even in vitro, the phrenic nerve recovers within 20 to 30 minutes. Even in vitro. And it can conduct the compound action potential again. Of course, we add the leak potential, the leak current into the model, and we get First, we get the compound action potential, which propagates. Then we get the delay in conduction, and then it's gone. And then when the recovery of the cell is there, when it depolarizes, it conducts again. The next one is hemolysis. It was a little bit, on a surprise size. And this is actually a paper that we just recently submitted to the JAC EP. The thing is that when we look at the data is really not very convincing. There's a cascade of events that happens. Obviously, we have hemolysis, which sometimes shows up clinically, and most of the time it does not show up clinically. Yeah? But there's always a little bit of hemolysis. And whether kidney is affected or not, it depends also on the patient condition. So when we looked at the literature, what we realized is that people were not using, let me say, the best biomarkers, or if they were using biomarkers that are good, they were off time. So the literature is not really very good. So when the literature is not very good, it's difficult to compare. The only thing that we can compare with is when you have head-to-head comparisons. And so there are some comparative studies which show which technology has more hemolysis than the other hemolysis and so on. All what they say collectively is the more you ablate, the more deliveries you deliver, the more applications you deliver, the more hemolysis you will see. But I still say we do not know whether there are patients who are more sensitive, whether there are patients who will have more hemolysis because of some, hidden hemolytic disease or something else. So one of the most, let me say, frightening or debated is the coronary spasm now. And the coronary spasm actually is on a low rate. What is interesting is that this was mentioned also by a previous speaker. Progressive coronary spasm during pulsed field ablation, and then you add, for example, nitroglycerin, and this prevents the spasm. And, well, it doesn't really, to be honest. Because, first of all, when you deliver pulses close to the coronaries, remember, coronaries have smooth muscles. Smooth muscles are stimulated by electric fields. So when you read this paper a little bit differently, every time they've seen, whenever they were delivering close to the coronaries, they have seen the spasm. Every time. But of course, it did not always show up as clinically relevant spasm. So that's a big difference. And so that leads to another question: how close can we be? And so one study says, this is from animals, 6-point-something millimeters, 6.5. Yeah. Again, in Paul's lab, we've done a study, and we continue to do that. And, one thing is, of course, that controlling the dose is essential in all these experiments. And you see that if we control the dose, we have no spasm if the dose is low, if the amplitude is low. We have a spasm which has which resolves by itself within 15 to 20 minutes, or it takes more than 30 minutes and it still does not resolve. Now, when it's clinically relevant, the spasm is when it gets to 90% plus. Yeah? So this is not clinically relevant, but it's there. It's even worse. With these two doses that do not recover, we see a clear histological damage to smooth muscle cells. Now, the smooth muscle cells are potentially leading to downstream to hyperplasia. So there's not enough, I would say, sensitivity for this potential complication. And I think this is one important thing. So if you tell the same thing over and over again. So it's non-thermal selective. Then people start to repeat that. When the people start to repeat that, it all of a sudden becomes truth. Yeah? And we know that. So it takes a lot of time to convince people that it's not completely non-thermal and it's not completely safe. Yeah? Now, a lot of parameters that you can change and play with. The problem is that there's I call it the PFA trinity. You have the catheter, you have the waveform, and you have the generator. It's not like software. You change something and everything works. No, there's a limit. Your generator can only deliver this. Your catheter will only survive this. And the waveform will only deliver this lesion. Now you change this, the catheter will not survive. You want to change this. Oh, they will tell you the generator cannot deliver this because that was not in the specs. Yeah? So you cannot really play a lot with this. So that makes it so difficult. The other thing is the lower you go with the duration of the pulses, below microsecond, not everything comes through. And all of a sudden, we have losses in the catheter. So the nanosecond pulses are a dream. What companies are delivering now is 0.3 microseconds. That's not nanoseconds, that's 300 nanoseconds. And I now read paper where authors claim that they deliver nanosecond pulses, 3,000 nanosecond pulses. Yeah? So now, and the design is always very critical in the medical devices. So it's this circle, you know, the sooner you turn back, the cheaper it is. But once you're at the clinical stage, it's almost impossible to go back. So it's going to take a while to actually get to the second generation of the catheters. We now live with the first generation, which is already very effective and very safe. But we have at least 2 decades of more research and development to get to the maybe second and the third. Now, I want to say that it's a very narrow path. And just at the time you think that you have now crossed the bridge, you find this kind of reports, yeah, like esophageal injury, yeah, like, you know, endothelial disruption, life-threatening delayed myocardial ischemia, and things like that. So we read about that virtually every week or month in this EP region. So it's really, I would say, not necessarily the job done. Yeah. Thank you very much.
Well, that was fantastic. Thank you very much. We have time for some questions. We're almost out of time, but we can go over a little bit. Anybody have questions from the audience? Otherwise, I'll ask one.
Sure.
Big thing is, both of you, maybe you want to stand up, Henri, is stacking. That's the big thing. Now I'm going to stack an RF with a pulse field, and do we know anything? Where's that what's gonna happen with that?
We know exactly. So first of all, we have 2 studies that are published preclinical. One says, yes, it makes sense. The other says, not so much. The first one says it doesn't really matter whether you do the PFA first or the RF first. The gain is there. And based on that, there's a first clinical study that is run. Yeah? And we're going to see the results. For me, it's too early. That's me. The second one says it's better to actually maybe use PFA, you know, all the way and do something to make lesion deeper. But no matter what I say is we have one dual energy system that is approved in US. There are going to be 3-4 more this year, according to FDA. And there are 2 in Europe. So whatever I mean, whatever I say, whatever I think, you're going to use it. So now it's up to you.
So yeah, basically we have. Yeah, so basically, I concur. Our experience has been also that to really assess these lesions, you have to wait longer than what you would wait with RF. And obviously, you have to convince your lab that they need to calm down and wait that length. So we wait 45 minutes for some of these lesions, especially if we use it in the ventricle. But yeah, the data, exactly what he just said, is the stacking of the lesions, especially in a thick tissue. You see the added after 2 or 3, and then the 4th, and then the added after that doesn't. But then that does not transpire in all, and depends. And I did not dive deeper into what exact recipe they used for each of these stackings and how far they distanced them from each other.
Well, the two studies, the one by Atul Verma, it's actually, I asked him because I read the paper and it's not there. It says immediately. Now, in engineering, we use usually numbers and units. And I asked, how do you translate that into seconds, for example, or minutes? And he said, it's 10 seconds. It turns out it's 20 seconds because the device requires 20 seconds to switch. So you see, sometimes it's not driven by the intelligent thinking or the design, but by what the device allows you to do. Yeah? And this is where we are right now. The device allows you to do. And that, for me, it's a challenge because I also asked electrophysiologists, so why are you... There was a presentation last week in Paris, and somebody said, and we do the RF first, and then we deliver the PFA in ventricle. I said, what is the motivation to first use the RF and then the PFA? And the answer is striking to me, but because if we use the RF and we eliminate the tachycardia, then we know we've done it because the signals are gone. But if we do that with PFA first, we lose the signals and we don't know whether we have done it or not. So the clever thing is you first do the RF, and then if the job is not done, you add PFA. Is that correct?
Yeah. So, but this is double-edged sword. So for us too. So because so the thinking from that is that you're counting because the RF you can deliver by that specific catheter, especially if you're doing sphere 9, is short, high duration. So your reach is a little bit less. So you hit bigger, wider. At the depth, you have to repeat the RF or prolong it or modify the numbers, which is very frowned upon by Medtronic, by the way. If it's for record, shouldn't do that, but I've done it in the lab before. So they count on PFA, they count on that lesion to be a bigger lesion if you stack it. So that's why they test with RF and do PFA. But you can also argue the exact opposite too, is that you're causing also edema and thickening of the tissue with RF first, and you're delivering PFA after. So you're increasing your distance to target, potentially.
The same happens with PFA. You also build the edema and so on.
Yeah.
So,
Question over here.
So you're talking about durability of therapy and getting feedback that you've been effective. We also talked a little bit about field shaping for some next-gen catheters, and I just wondered, are there any catheter technologies, feedback tools, things that you'd like to see developed in second and third gen that you can speak about?
yeah. Well, first of all, field bending is marketing. Yeah. We do bend the field all the time. It bends on itself, actually. It's impossible to get it not bend it. So what the field medical has is it has higher voltage. So the dominant parameters that drive the lesion depth is the voltage, the amplitude, and the duration of the pulse. Yeah? And if we are limited with the duration, then it needs to be the voltage. So that's the trick. Now, when we want to drive the voltage, now, since you asked, yes, please, we would need the contact sensor that survives more than 2000 volts, and we would need the magnetic sensor that survived more than 2,000 volts. So now you know. When it's done, let me know, please.
All right, I think we should end here. Fantastic lectures. This was a great cardiac keynote session. It's probably the tallest pair of cardiac keynote speakers we've had, by the way, in 25 years. So again, thank you.
Including the chair.
Thank you very much for your lectures, and I'm sure they'll stick around if anybody has any specific questions. And sessions again at 3:30. So thank you, the speakers again.